Doctor, can we start this next session?
Start the next session. Good morning, all. First presenter, please. Aparna. Aparna, are you there?
No, ma'am.
I Nala.
Dr. Abhishek.
Okay.
No, Dr. Abhishek is not there. Dr. Akshay?
Dr. Rashmi.
Sir, yes, sir, I'm available, sir.
Dr. Rashmi, can you please present your paper, please?
Yes, sir, yes. And my slides are visible, sir?
Not yet.
Is it visible, sir, now?
Yes, it is.
So, good afternoon, everyone. Today, I'll be discussing with my paper on topic efficacy of peribulbar versus topical with intracameral lignocaine anesthesia in small incision cataract surgery. So, as we all know, cataract is the most common treatable cause of blindness in elderly population. Anesthesia is an integral part of cataract surgery with patient comfort, safety, and low complication rates being the essential part of it. So peribulbar anesthesia remains the most common type of anesthesia used, but comes with its own disadvantages. Topical and intracameral anesthesia are new options for pain control in modern cataract surgery. So aim of my study is to compare surgeons' experience during surgery under both anesthetic technique and to evaluate the surgical outcome in both the groups. So the study design here is a single center prospective observational study. Study setting consisted of 120 consecutive patients, which were divided into 2 groups, that is 60 each. 2 minutes, 1 minute, sir. I just. Patients were divided into 2 groups, that is group 1 was peribulbar and group 2 topical group. There was an exclusion criteria which consisted of uncooperative patients were excluded from this study. Patients who are unable to understand and comply with verbal commands or visual analog scale, hypersensitivity to xylocaine, those having corneal dystrophies, degeneration, obesities, and corneal thinning, and one-eyed patients. Parameters assessed in both the groups were kinesia, complications, postoperative analgesia, and surgeon's experience during surgery. So there were baseline characteristics like in terms of age and gender distribution. There was no statistical significant difference in both the groups. So kinesia in both the groups was studied, which showed that at 96% patient had lead akinesia and 100% patients had low kinesia in the peribulbar group, which lagged in all the patients of the topical, which was statistically significant. Steps of surgery at which pain occurred showed that there was a statistical significant seen in group 2 when compared to group 1. That is, during scleral incision 18.33%, tunneling 10%, cortical wash showed 13.33%, cauterization showed 8.33%. There was no statistical significance between both the groups when in terms of during nucleus dialing, nucleus extraction, and intraocular lens insertion. So complications during administration of anesthesia. So complications like chemosis, subconjunctival hemorrhage was seen in the peribulbar group, which was statistically significant. Corneal aberrations and giddiness, other complications were not seen in group 1, and it was not statistically significant. No cases of retrobulbar hemorrhage, globe perforation, optic nerve injury, loss of consciousness, respiratory arrest, cardiac arrest had occurred during the study. Intraop complications, like none of the intraocular complications were statistically significant among both the groups. Blepharospasm was numerically higher in the topical group, but it was not statistically significant. So we had studied analgesia, that is at 0 to 1 hours after surgery, which showed no statistical significance between both the groups. Whereas the analgesia at 4 hours after surgery showed that 68.33% patient had mild pain and 10% patients had moderate pain in the peribulbar group, which was statistically significant. None of them had severe pain in both the groups. Patients' cooperation in both the groups, that is surgeon's experience in terms of patient cooperation, 96% in the peribulbar versus 73.3% in the topical had excellent cooperation. 3.3% versus 23.33 in topical group had a good cooperation among both the groups. Poor cooperation was seen in 3.3% of the topical group, that is group 2, which was statistically significant. The next parameter in surgeon's experience studied was difficulty due to ocular movements during surgery. 96.66% in peribulbar versus 75% in topical patient had no difficulty among both the groups, whereas 3.33% in peribulbar and 25% in the topical had some difficulty, which was statistically significant. The anterior chamber stability was studied in both the group, and it showed no significant statistical difference in both the groups. So the discussion part here is, in the present study, it was noticed that lead akinesia and lobe akinesia were significantly better with peribulbar anesthesia. Complications during anesthesia were significantly more common in peribulbar group. Significant pain during steps of surgery was noticed in topical anesthesia. Intra-op complications were not significantly different among both the groups. Pain 4 hours post-operatively was significantly worse in peribulbar group. Patient cooperation and difficulty due to unwanted ocular movements were significantly better with peribulbar group. So we conclude here that better communication, calm and cooperative patients are ideal candidates for topical anesthesia. Careful patient selection is very important. Topical anesthesia is safer and effective alternative to peribulbar in cataract surgery. So we need good surgical training, careful selection of patient, good preparation and education of patient to further minimize the pain and discomfort in topical anesthesia. Thank you.
Rashmi, it was a very good presentation.
Thank you.
My only question is putting a bridle suture in
Yes,
a
sir.
case of topical anesthesia.
Yes,
What's
sir.
your experience in this?
Sir, few patients complained of pain during bridal sutures, sir,
Okay.
in topical anesthesia.
And
Pain
do you
was,
have any patient when doing topical vasovagal attack?
in my study as such, I didn't come across.
Okay.
Okay, Rashmi, am I audible?
Yes, yes,
Yeah.
sir, yes.
Yeah. So, what do you want to tell now? You should, with your study.
Sir, I would like to comment that now, like topical is the more, it is the recent trend with intracameral, but we need proper selection of patient and proper communication with the patient before we start and finish our procedures.
No, but proper selection means what? Did you select it properly? If you
Actually,
have
sir,
selected it properly, then those patients should not have had it, right?
yes, sir.
So
But
then in
in
that
our,
case,
yes,
in that case, you have to do one more study by properly selecting and analyzing whether these properly selected topical patients had less pain and other things, right?
yes, yes.
So take home is whether we should do it or not do it.
Sir, depends upon the patient, sir. Like if we are selecting camp patients and all, I would prefer peribulbar, sir.
No,
compared
you
to-
cannot differentiate between Ambani and street side, right?
Yes.
When
yes,
we propose a treatment plan, it should be,
yes,
it should hold good for everybody.
yes,
Okay.
yes.
Dr. Rashmi, can you hear me?
Yes, sir. Yes.
Yeah. Have you used the intracameral anesthesia in all the patients who were operated under topical?
Yes, sir. Since my study was both topical as well as intracameral, sir. Topical I have used 2% lignocaine jelly, and intracameral I have used preservative-free 1% lignocaine drops,
Okay.
injection forms.
Yeah, you said pain happened during the cortical wash in part of your study. Was
Yes,
that was that for the topical group or was it for the peribulbar group?
sir. Pain occurred. It was like in the topical group. It was seen, sir, like during cortical wash.
Then what could be the reason why the patient had pain during the cortical wash?
Sir, probably we'll be going a bit deep and we'll be touching iris and ciliary body. So the topical anesthesia, it works superficially, sir, up to cornea and the other part. The inner structures are not well anesthetized with the topical.
But you already mentioned that you are used intracameral lignocaine.
Yes, sir. Intracameral lignocaine.
Unless there is stretch on the ciliary body.
Sir?
Unless there is a stretch on the ciliary body, iris doesn't cause pain. Touching
Yes, sir,
iris
yes.
during cataract surgery doesn't cause pain.
Yes, sir.
But when you try to have a pull on the ciliary body, that
Yes,
does cause pain. So that is the reason why your cortical wash was,
Yes,
where there was a
yes.
pull on the ciliary body rather than touching the iris.
Yes, sir. Yes.
Okay. And yeah, regarding that question, what Dr. Shankar Gowda asked you,
Yes.
had you used bridle suture in all these patients with topical anesthesia?
Sir, for peribulbar, I had used bridle suture. Sir, for topical, I skipped the steps.
Yeah, no, it should be skipped. You cannot use bridle suture in a topical anesthesia patient. Okay?
Yes, sir. Yes.
The patient can have a vasovagal shock and he may have other complications. So you should never try anything under topical anesthesia other than the speculum.
Yes.
Okay. So what is the take-home message now at the end of your study?
Sir, both have their own pros and cons, sir, when it comes to choosing a proper anesthetic technique. So, but still, with the advancing era, I would like to go with topical, sir. Topical with intracameral, which is better for better anesthetic techniques, both like economically as well as when it comes to patients' cooperative things.
Okay, thank you.
Okay. Thank you, sir.
Can we go on with the other three paper? Dr. Sharda?
Sir, present. Is my screen visible, sir?
Yes.
Okay. Good afternoon, everyone. I'm going to present a paper on a clinical study on evaluation of risk factors and visual outcome after phacoemulsification in presenile cataract patient. My chief author is Dr. Sangmeshwaraya B. Salimat and I am Dr. Shraddha Malik. Introduction. Cataract is a major cause of blindness worldwide with a greater prevalence in developing countries like India. Presenile cataract refers to an onset of cataract anytime from 35 years to 55 years of age. In India, almost 62.6% of blindness is attributed to cataract. Data from a study carried out in Punjab showed that the age-specific prevalence of cataract in India was 3 to 6 times higher than that in the Framingham Eye Study in the United States. Purpose of the study, it is to know the risk factors associated with presenile cataract and also to know the visual outcome of presenile cataract after phacoemulsification surgery. Methodology, patient consent was taken before conducting the study. Clearance was taken from ethical committee. This is a case series study of 50 patients of presenile cataract patient with unilateral or bilateral cataract undergoing phacoemulsification surgery at our hospital based on inclusion and exclusion criteria during June 2020 to November 2021 after being investigated for HIV, HCV, HBsAg, and RBS. The visual acuity was tested using the Snellen's visual acuity chart. The anterior segment of the patient was examined with slit lamp. After fitness and basic investigation like lacrimal syringing, tonometry, keratometry, they were posted for phacoemulsification cataract surgery. Detailed history is taken regarding the patient's risk factors such as diabetes mellitus, eye myopia, occupation, dermatological diseases like atopy, and smoking, and were also inquired about the history of chemotherapy, radiotherapy, chronic intake of corticosteroid, substance abuse, and history of early onset of cataract in the family. Patients were evaluated about risk factor for recent cataract and visual outcome in recent cataract patient who underwent phacoemulsification was noted. Results: in my study, diabetes was the major risk factor. After that, tobacco consumption stands second, and eye myopia and dermatological diseases at same incidence. Long-term use of steroids and idiopathic were also there. Gender: 28 in my study, 28 persons were with presenile cataract were male and 22 were female. Age-wise distribution of the patient in my study, 51 to 55 years patients were more prone for presenile cataract. Type of cataract in my study, there were total 10 patients with posterior subcapsular cataract and 11 patients with nuclear sclerosis and 26 patients with cortical cataract and 1 with hypermature cataract and 2 with posterior polar cataract. Discussion: if cataract occurs in the working adult population, it can affect livelihood. Various studies have shown risk factors of presenile cataract to be smoking, alcohol, and diet, atopy and axial myopia, long-term use of corticosteroid, and exposure to ultraviolet beta radiation. According to Rahman et al. And Jyoti et al., most cases of presenile cataract are idiopathic. In our study, we observed male preponderance for unknown reasons. Sai et al. Reported that the average age of 45.5 plus or minus 7.6 years for presenile group, which is almost the same in our patients. However, there was an earlier age of onset in male patient as compared to female, reported by Kalsian et al. We found a strong association of diabetes as a risk factor for presenile cataract. Accumulation of sorbitol within the lens changes its hydration and alters its metabolism in diabetic cataract. After diabetes in our study, tobacco consumption and association with presenile cataract. The human cataract's lens shows almost 50% deterioration in calcium ATPase activity, resulting in intralenticular calcium deficiency compared to normal lens. It may be correlated to a study on animal model which demonstrated cataractogenesis as a result of disrupted ocular calcium homeostasis due to cyanide exposure from tobacco. Among the modifiable environmental factors, tobacco consumption has been proved to be responsible for cataract. In our study, we noted an equal incidence of occurrence of presenile cataract in eye myopes as well as patients with dermatological diseases. Praveen et al. Reported myopia to be risk factor for presenile cataract. Endoplasmic reticulum stress and a problem response on the lens epithelium result in an early onset of cataract in eye myopia. In our study, we also noted equal percentage of patients with long-term steroid intake history and idiopathic cause as risk factor for presenile cataract. The preoperative and postoperative best corrected visual acuity between the various age group was compared by applying ANOVA test. It was found not to be significant. However, the visual improvement in all age group was found to be significant by comparing the preoperative and postoperative visual acuity. The final visual acuity ranged from 6/6 to 6/12 in all 50 patients. Conclusion of my study: strong risk factor for cataractogenesis in our study was diabetes mellitus, followed by tobacco consumption, eye myopia, dermatological disease, and long-term usage of steroid in presenile age group. A significant visual improvement result after phacoemulsification cataract surgery and lens implantation. These are my references. Thank you.
Dr. Shraddha,
Sir.
Among your patients with senile and presenile cataracts,
Sir.
did you do any investigation in terms of serum vitamin D?
Sir, vitamin C, sir.
Serum vitamin D.
Serum vitamin B. No, sir.
It has been found to be one of the implicated factors in early onset of presenile cataracts.
Okay, sir.
Especially now in most of the Indian population,
Sir.
who are more vitamin D deficient.
Sir.
So the preponderance of incidence of cataract is quite
Sir. Because of poor diet and.
So that was one of the parameters you should have included in your study.
Okay, sir. Okay, sir.
Dr. Shraddha,
Sir.
what is the visual outcome, and did you consider the corneal specular and phaco time in the
Sir, phaco time was US time was 1 minute and 21 seconds, sir. We have used phaco chop technique for mature cataract and stop and chop technique for immature cataract, sir. And visual acuity were 6/6 or 6/9, sir. They were good, sir, after phaco emulsification.
Dr. Shraddha, what was the grade of cataract in majority of the patients?
Immature cataract, sir. Nuclear sclerosis grade was there, sir. Only one case had hypermature cataract, sir. Most of them were immature cataract.
So which risk factor you want to concentrate more here?
Tobacco consumption, sir. As we can
What was the
avoid
percentage of people with tobacco consumption had the
20%, 20%, sir. But diabetes mellitus, we can control the sugar levels. That's all, sir. But tobacco consumption, we can avoid so that there won't be any presenile cataract.
Okay, so tobacco, the sugars, of course, it is a day-to-day problem.
Sir.
Tobacco is a habit which can be
we left.
stopped. That is what you want to tell.
Sir.
Okay, good.
Okay, sir. Thank you, sir.
Did you consider the duration of diabetes?
Duration of diabetes were like around 5 years only, sir. 5 to 6 years only. In only one study, it was around 10 years, sir. Living that everywhere, like 4, 5, 6, like that only it was there.
And,
I had taken the history, sir.
Okay, and what about the control of diabetes in that 5 years?
Control, like there were alterations, sir. The wide range was there, sir. Like there used to be very hypoglycemic and hyperglycemic levels, sir. They had not properly controlled, sir.
So you want to say that uncontrolled diabetes lead to early cataract?
Sir. Uncontrolled and duration also, sir.
Person who has also tobacco and diabetes, what do you attribute to more?
I attribute to diabetes only, sir.
Whether you did a comparative study, like a person with only tobacco, person with diabetes, and person with tobacco and diabetes.
No, sir.
That would have given some
better.
In your study, how many were tobacco users and tobacco?
Tobacco users were 10 people, sir.
And diabetes
both were 20 people.
Both
were around 7 or 8, sir.
Okay.
I have not like separately. I have not did any studies.
Good presentation.
Okay, sir.
Good paper.
Okay, sir.
Let's go to the next free paper.
Thank you so much.
Yeah. Let's go to the next free paper, Dr. Sayog. Are you there?
Yes, sir. Yes, sir. I'll be sharing the screen, sir. Good afternoon, everyone. Everyone can hear me?
Yes.
Good afternoon, everyone. My name is Dr. Suyog. I'll be presenting a free paper, a study of visual outcome and complications following NDR laser capsulotomy in postoperative PCO. The Posterior capsular opacification is one of the most common late postoperative complication of small incision cataract surgery and phacoemulsification. The incidence of PCO was reported to be 20.7% at 2 years and 28.5% at 5 years after cataract surgery. Initially, PCO used to be treated surgically, but now NDA laser capsulotomy remains the cornerstone in its treatment. Even though laser capsulotomy is easy to perform, it carries risks like elevated intraocular pressure, retinal detachment, iritis, vitritis, CME, etc. Main objective of the study was to compare the visual acuity before and after NDA laser capsulotomy in posterior capsular opacification and to look for complications following NDA laser capsulotomy. Our study was a prospective study conducted over 6 months. A sample size was calculated to 50 based on M&A equation. And source of the data
your
was
slides are not moving.
So now?
No.
No. Here with the title slide.
Yeah, big screen, please. Full screen.
Sir, now, sir?
Full screen, yeah.
Yes, sir. Sir, now, source of data, 50 patients with the posterior capsular opacification attending the ophthalmology OPD during the study period were included. Inclusion criteria, patients with PCO with or without symptoms. Exclusion criteria, patients were patients who not giving the consent for the study, patients with active inflammation who underwent cataract surgery within 3 months, is with high intraocular pressure, with retinal diseases. Again, sir.
You should simultaneously move your slide and yeah.
No, sir. I think internet issues. Hello.
Yeah, continue.
Hello. Yes, sir. Exclusion criteria also included patients with corneal pathologies, posterior segment pathologies which affect vision, and patients with high myopia. Methodology, on first examination, detailed history was taken. Anterior and posterior segment examination was done along with best corrected visual acuity using Snell and Stratt. Once diagnosis of PCO was made, patients were explained about the procedure and consent was taken for the same. Under topical anesthesia, NDA laser capsulotomy was performed. Care was taken to use a minimal amount of energy required. Intraocular pressure was recorded before the procedure, 1 hour post-procedure, and on subsequent follow-ups. Post-procedure, topical steroids, NSAIDs, and anti-glaucoma drugs were advised. During follow-ups, along with best corrected visual acuity, patients were examined for complications like raised IOP, hyphema, IOL pitting, iritis, retinal detachment, CME, lens subluxation, or dislocation. Results. During the study, 50 eyes of 50 patients were assessed and the following observations were made. 18 patients belong to age category of 40 to 60 years, 31 patients in between 61 to 80 years, and 1 patient more than 80 years. There were 52% female patients and 48% male. The time interval between cataract surgery and PCO was noted. There were 6 patients with 6 months to 1 year of interval, 18 patients with 1 to 2 years, 12 patients with 2 to 3 years, 8 patients with 3 to 4 years, 4 patients with 4 to 5 years, and 2 patients more than 5 years. But best corrected visual acuity before and after capsulotomy was as follows. Pre-laser, highest number of patients had a visual acuity of 636. Post-laser, highest number of patients were seen with the visual acuity of 6/6, that is 19 patients. 47 patients had raised IOP post-capsulotomy when compared to pre-laser levels, but only 5 of those were above the normal range. 2 patients had IOL pitting and 1 patient had iritis. We also tried to associate complications with the total energy used during the procedure. In patients with no complications, mean total energy was 32.2 millijoules. In patients with IOP spike, mean total energy was 32.5 millijoules. That in IOL pitting patients were 38.5 millijoules. And in case of iritis, total energy was 42 millijoules. Discussion. The posterior capsular opacification is one of the most common late postoperative complication. In our study, post-laser, 54% patients had best corrected visual acuity of 6/9 or more, and 34 patients got best corrected visual acuity between 624 and 612. A study by Patil MS et al. Showed a post-laser 67% patient had a visual acuity of 6/9 or more, and at 3 months follow-up, and 30% patient had visual acuity of 624 to 612, which was similar to this shows our study was similar to that study. Vision improvement was present in all the patient, and it was at least by one Snellen's line. This was probably due to exclusion of cases with pre-existing ocular pathology, which could prevent improvement in visual acuity. 47 patients had raised IOP when compared to pre-laser levels. 10% had IOP above the normal range. All the patients with IOP spike returned to normal levels in subsequent follow-ups. Lens pitting was seen in 4% of patients, and iritis was seen in 2% of the patients. Complications were observed in those patients with high mean total energy. Ayub Karan et al. In their study concluded the complications, especially rise in IOP, seems to be unavoidable after NDR laser capsulotomy. Using less total energy and performing smaller capsulotomies are practical choices to decrease complications after NDR laser capsulotomy. In conclusion, NDR laser is easy. Capsulotomy is easy, non-invasive outpatient procedure, less time consuming, and causes less discomfort. It is highly effective in improving visual acuity in eyes with PCO. Although this procedure is relatively safe, it is associated with complications like transient intraocular pressure rise, pitting of intraocular lenses, mild iritis, which are not vision threatening and they are transient. Using less total energy and performing smaller capsulotomies are practical choices to decrease complications, and follow-ups are must to look for complications. These are my references. Thank you.
Good presentation, Dr. Zayov. My only question is, how long do you give the post-operatively drugs to the patients?
Sir, we started the combination of moxifloxacin and dexamethasone QID and tapered it off with 5 days, sir.
Tapered it after 5 days. How long?
Yes, sir.
How long?
2 weeks, sir.
2 weeks.
Yes, sir.
And
in your studies,
yes, in your studies there was 30 to 35% which were having less than 624. Why was that?
Sir, that was actually not evaluated in detail, sir.
They had some ocular pathology because that was the exclusion criteria.
Yes, sir. They didn't have any on examination. We didn't find any ocular pathologies as such.
But 34% is significant, I think.
Yes, sir. Yes, sir. But when compared to pre-laser levels, there was a significant improvement in visual acuity, sir.
Another aspect, what type of PCO you have not considered?
Not in this study, sir.
Not in this study.
Because
there is a ethnic pulse, there could be a fibrous PCO.
Yeah, fibrosis also. Yes, sir.
And type of IOL used also you have not considered.
Actually, we tried to include it, sir, but due to issues with the this one documentations with the patients, we couldn't get the type of IOL which was used and all.
Okay. And pitting was more seen in which type of IOLs, of foldables or PMMA?
Sir, this was seen in both the cases which we saw was a PMMA, sir.
So the pitting, what you said, was related to power usage or anything else?
Sir, in this study, the total mean energy used was high in IOL pitting.
That
sir.
is what, whether
But,
you attribute the pitting to the power usage or anything else you want to attribute it to.
Sir, the doctor's skill also matters in this complication.
So
sir.
then pitting is not associated with increased power consumption. It is the focusing.
Yes,
Okay, that doesn't fit there.
Yes, sir.
And one more thing, Sayog,
Yes,
what is the duration you give anti-glaucoma drugs to a patient?
Sir, this was till the patient had normal IOP levels, sir, like on follow-ups.
When is the follow-up of this patient?
Sir, one follow-up the next day, one after 1 week, and one after 2 months, sir.
And you found the IOP to reduce in what time?
Within 1 week, sir. By
week.
1 week follow-up, it reduced to baseline levels.
Only steroids or NSAIDs would be better?
Sir, NSAIDs, we combined both steroids and NSAIDs, sir.
No, because iritis you have mentioned around 42, this means more of iritis was there. With,
Sir, this was mean total energy, sir. Only one patient had iritis. We suspected poor compliance by the patient, sir.
And IOP spike could be due to only due to steroid use?
It can be, sir. Not as such, but because once after 1 hour after procedure, we checked there was IOP spike in almost all of the cases, like in 48 patients, sir. So this was before prescribing any steroid drops for the patient.
So you mentioned that you had used the antibody steroid combination in these patients for preventing the UA.
Yes.
Why was the antibiotic steroid combination preferred?
So as prophylaxis, we prescribe them, sir.
Antibiotic has got no role in.
No, sir. As such, no role in this.
Should have used only a steroid and preferably an NSAID if at all you wanted to prevent the uveitis subsequent to your procedure.
Yes.
But
yes,
usually there will be a transient rise of IOP immediately after the YAG capsulotomy. So which is the ideal drug that should be used for preventing the IOP spike in the patients with say where you are planning for YAG capsulotomy?
Sir, acetazolamide tablet can be prescribed, sir, or topical timolol can be given.
No. All these drugs, they have a certain duration of action. The onset of action will be delayed, and by the time the IOP spike would have already happened. So apraclonidine 1% is the most ideal drug for for these kind of procedures. And when was the first IOP say checked immediately after the procedure?
Sir, immediately after the procedure and at 1 hour interval, sir.
Yeah, what was the IOP spike like following each of your procedure?
Most of.
How much spike was noted?
All the cases had raised IOP, sir, but only 5 of those were above the normal range, from 25 to 30.
25 to 30 millimeters of mercury?
Yes, sir.
All the patients?
No, sir. 5 patients.
5 patients. 5 patients out of?
50.
Out of 50, sir.
Okay. And for visual outcome, did you do any macular function tests after the last follow-up in terms of visual acuity?
No, sir.
This was your visual outcome following capsulotomy.
Yes, sir.
Vision was checked
only
after how many days of this again? Best corrected visual acuity?
Sir, on each follow-up, it was checked, sir. Till 1 month follow-up, it was checked, sir.
Okay. And 35% did not show any improvement.
No improvement, sir.
So how do you account for the loss of vision in these patients?
Sir, sir, maybe macular pathology, sir.
Yeah, if there is a subclinical CME or an established
Yes.
cystoid macular edema, so all those documentations are important to come to a conclusion that why 35% of the patients did not improve in spite of doing the capsulotomy.
Yes, sir.
So OCT studies were not carried out.
No, sir.
No, what was the reason for that?
Sir, financial issues, sir.
Okay. No, the patient's finances or the institute was not?
The patients, sir. And my study was not funded, sir.
Okay, thank you, Sayog.
Thank you, sir.
Is Dr. Abhishek is there? I think we should conclude the sessions. I think only 4 papers. Dr. Seth.
Yeah, out of 4 now we have
Covered 3.
Only 3. Yeah.
Okay.
So we'll have to mark Dr. Abhishek as absent.
Okay.
Okay.
Thank you, everyone.
Sir. Hello, sir.
Yeah.
Sir, I am Dr. Supriya, sir. My paper is also there.
Sir, my paper.
No, we do not. I think when is your session? What time?
Sir, mine is optic and refraction only, sir. Contact lens.
And what was who is the judges like? Because we were given only these 4.
Sir, it is included among these only. Abhishek, Shraddha, Rashmi, Suyog, and mine.
So our time was 10:30 to 11. Sir, Anusha and all also, sir, we were given time from 10:30 to 11:55 in Hall E, so we were sent that link only.
Sir, mine is 12 p.m. to 1:25 p.m. in Hall E, sir.
Supriya. I think you can contact the this person, the IT person, so they can fix because the judges are different for you. We are not the judges.
We have been allotted only these 4 papers. And without informing the scientific committee people, we cannot judge your papers.
Sir,
ma'am, please leave message in your chat box. I'll check and I'll get back to you.
Okay.
Your topic and participant name. Okay.
Okay, madam.
Okay, sure. Thank you.
Okay, madam.
Thank you, everyone.
Thank you, doctor.
Thank you, Alpesh. Thank you, Shankar Gowda.
Thank